look like little Cheerios because we're looking straight down the barrel of the lead, and the contacts are shaped differential, so they look like loops. Okay, so when we place this, we want to be in the superior dorsal space so we aren't getting motor snap. The placement is similar to an SCS in terms of epidural access as our first step, but our skin insertion site's a little bit different. So here's a picture of this same lead placement, same needle placement. And if we were doing SCS at this level, we'd be with an angle like this, right? Yeah. But we're actually going to start just on top or outside of the pedicle at the level below our epidural access. So if I want to treat right T12, I'm going to access T12, L1, but I'm going to start at L2 on the opposite side. And so I can draw this out on the patient. Target pedicle, midline access spot that I want to get to, and then the pedicle for my skin entry site. And I can do that by just laying in an AP view a spinal needle or this needle on top and really make sure I like my trajectory. And I can take another needle, I can cross it over there on x-ray and raise my skin wheel there. And I've got a nice entry site that's going to take me triangulated towards this loss of resistance site between the middle and lower third, right at that junction, as close to the midline as possible, trying not to cross, trying also not to end up on this side because there's a convexity to the dura in the epidural space, and you want to be on the vertex of it. You don't want to be sitting down looking at the vertex. This is our superior loop. It hugs the pedicle. We want our contacts either 2, 3, or 3, 4 to be sitting under the pedicle. The DRG is going to sit effectively right in this region here. Superior loop, inferior loop, and then another superior loop. And this is our introducer sheath that's been pulled back into the needle. It's got a radio-opaque tip to it so we can tell where it is and where it's moving. The electrode has a stylet in it that allows us to make it either more springy and tensile or spring-loaded. And when we pull the stylet back, it allows us to sort of leave these ribbons of loop behind that create a passive loop that's going to sit in space with strain relief provided by that ribboning from that S or strain relief. Okay. The way that we deploy the electrode is first we get our loss of resistance. Yes, please. Thank you so much. Thanks, Sean. The system itself, right, is using this rigid introducer sheath. This one's kinked, so we're going to get rid of it because once the sheath gets kinked, the lumen changes its shape and you're going to have a catch point there. So how do you avoid kinking sheaths? Being gentle. And then also recognizing that one of our first steps in this procedure is taking a bent introducer sheath with either a lead or a guide wire loaded in it. Makes it more rigid, makes it less likely to be, makes it more steerable, makes it more deadly, okay? But we're gonna be gentle, so we're not gonna do anything deadly with it. And you're gonna hold it like a dart. The needle that we're using is special in that the bevel is marked on the hub. Its location has a black line, and the opening or bevel to that needle is directional and marked and lines up with that line. And it also allows us to understand that once our introducer sheath is in there, we know where the orifice of the needle is or the bevel is, and that we want to line up with the bend, which always correlates with the injection port. So if the injection port is up and the black line is up, we're going to see the sheath come out with whatever's loaded in it once this white line gets to the tip, and it's going to come out with the same angle because lined up together. Once I'm in the epidural space, I'm going to stay facing the 12 o'clock position. I'm going to drive up cephalad towards the target level, and we're going to turn both the needle and the introducer sheath towards the foramen. As we push over, we're going to see it travel laterally, hopefully not falling into lateral recess too soon, but as it's approaching the upper part of the foramen or the lower part of the pedicle that we're targeting. So it's kind of helpful to see all this outside of the body before we start doing it inside, and there's superficial things that let us know what's happening inside besides our fluoro. Like I said, the marker that lets us know when we're exiting, as well as the direction of that of the bend in our introducer sheath with the injection port location. Really trying to keep these things in sync as we do the procedure. So we've got our epidural access, and we're going to now hold this like a dart, because as I pass this through, it's going to need to deform into a straight line, which is going to have some resistance. So I'm going to hold onto the hub, and I'm really minimizing the amount of space between my grip and the exposed introducer sheath. because then if there's very little space here, it's hard to kink it. So I'm just going to advance a little bit of pressure. I'm just trying to get it to deform so it doesn't get stuck and it doesn't kink. And sometimes what happens, you're going to feel that click. And I felt that click and I know that it's now in there. And sometimes I notice as I've done that, my ports are already misaligned. And I can easily just go and grab this and just apply a little firm pressure and turn it inside. I can hear it and it's now realigned. I'm just going to advance this back down. Remember my white, I don't need to shoot any floor to see where it is because I know I'm still in my needle until I get to this first white line. I get to my white line and then I'm going to look at the screen. I'm going to take a shot. And I can see that right now, my injection port is turned to the side, and that's why on the screen it looks like it's heading towards the right. So I'm going to turn that back up towards cephalad, and we're going to take a shot there. And let's go live. And as we go live, I'm sort of steering. You can see the steering of the introducer sheath, the guide wire, and I can just kind of bring it over towards that top of that pedicle there. You can stop right there. What I'm feeling right now is a little bit of resistance as I'm hitting the interforaminal ligaments. They're like the strings on a tennis racket, all right? I'm now going to unlock this lure lock that kept my guide wire in place, and I'm now going to provide some gentle tapping to try to find that space in the holes. Let's go live. And as I'm doing that, I'm click, 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 and I can feel that the guide wire wants to come out, and it's passed right out of there. Stop there. Perfect. So this guide wire is not going to stimulate anything, right? So I've got to hold this in place and exchange it now for my lead. And my electrodes. Can you grab that for me? Thank you. My electrode right here. The 4 contacts has got a stylet in it. And my stylet is not all the way threaded in, so I'm going to do that. I'm trying my best to hold everything in place so that all stays there. Let's see, and once I'm in there, it'll be good. So I've now thread the lead in there, X-ray, and because my stylet's not all the way in, change my grip for a second, thread this in because I need my electrode to be rigid at the tip to pass through the ligaments just like the guide wire did, right? The electrode's softer, it's 1 millimeter. Let's go live. And I'm going to try to find a way to get the electrode to come out the same way the guide wire did. And sometimes it passes right back out, and sometimes I gotta go back and rotor it again, but there we go, and it passed. So I've now exchanged, but the way that I troubleshot that as a kind of resistance is I was actually rotating the injection port, which was rotating the tip, and finding that hole then in the tennis rackets where effectively I no longer am hitting the ligament, but I'm finding the space in between, and then it clicked out. The ideal location would be to be contacts 2 and 3 or contacts 3 and 4, 2 and 3 being ideal. 3 and 4 is okay because as I introduce my superior loop, I'm going to see the electrode start to kind of pull its way back and settle up against the underside of the pedicle. And so we're going to go X-ray there. And now I'm going to start to think about introducing my tension loop. So what I'm going to do is I'm going to pull my sheath back, the introducer sheath back, and it's going to leave the lead behind. And so I'm going to do that under live. As I pull that back, you can see the introducer sheath is pulled back towards the needle. And my dot's right there again, so I pulled it all the way back in. I was facing lateral, now I want to come back superior because I'm going to introduce the superior loop by advancing my introducer sheath just about a centimeter cephalad in the epidural space in the midline. I'm going to feel click again because I just popped out X-ray, right? And see how right now what's happening is the electrode is actually moving itself over towards the side. I want the electrode to hug that pedicle. So what am I going to do? I'm going to turn this towards the right, X-ray, and I'm going to actually push up, X-ray. And what's happening is I can see my contacts are out, so I'm going to pull back my lead a little bit, X-ray. It's going to put it into a better position, X-ray. And X-ray. Good. And what I'm going to do is after I have it in a position like X-ray, we're going to go ahead and put that superior loop in. Live. Live. Thank you. And as I put this up here, I want to drive up so that the lead is going to hug that pedicle like that. Stop. So I use the introducer to sort of drive up and hold it in place. But if I start threading my lead out now, it's going to pull the electrode out of the frame. And so I'm going to pull my stylet back. As I pull my stylet back a couple centimeters, it's going to soften that up there. I'm going to go live. And as I put in a little extra lead, I'm going to watch it form my loop. It's going to hug that pedicle. All right, and then as I pull my introducer back, it's naturally falling over to put in my inferior lead. And what we just saw is that little turn there. None of us want that because that's torque on there. And what's usually happening is it means I need to pull my slide back a little more. So I pull my slide back a little more, putting that loop back in, and now I'm going to rotate everything towards there. Then we're going to go live. We're still there. And you can see how dynamic this system is. It's like throwing a lasso, right? And I'm just going to pull this back a little more, and then stop. And then I'm going to put in one more superior loop. Extra. Single shot. Have a single shot. Thank you. And we're going to go live. And putting in just one more superior loop there. And if I push this, my guess is it's going to sort of anchor everything right into place. I don't need all that loop. Stop. And so I can always pull some of it back later. X-ray. And X-ray. You have a really nice S loop there. One more shot. Okay. Ideally, I'd want this to be hugging the pedicle, but the femoral ligaments will typically hold this into place. And now that this is all facile, this would heal into place very nicely. I've got a good tension loop up, down, and another one up. And I would anchor this at my cut down site right here to the fascia, so that way when the patient moved, it wasn't causing a whole lot of translation of the lead distally. Okay, or fractures or migrations. So it's